Okay, here we go. All right, so the red button's on. That means we are recording. All right, so guys, this is the Endocrine Lab. It's our last lab. So we're going to be going over this chart. Let me share my screen again, and we'll kind of be going over this together. And now some of them, there's going to be some blanks that you may have to go back and fill in yourself, because I don't want to try to do everything, but I do want to try to fill in enough of these to where you have an idea of what kind of hormone that we're talking about. And, you'll probably find the answers mostly in the case studies. We're going to go over that next. We're probably going to do all that together. The quiz will likely be I think it is the case studies. You have about 15 minutes to do the quiz. It's 20 questions, 15 minutes. So the idea is that you would have these answers ready to go. Now, in light of the quiz, I've been behind. I haven't had a chance to grade our quizzes from last week. I'm assuming that everybody who attended last week kind of had an idea what was going to be on it. So you may have the right answers in there. If your spelling's off, that's okay. I need to go in there and, do my normal grading and correct everything. So that's next. That's what I'm going to do tonight, because I've been caught up reading Micro 225 exams, and I changed their format to where it's all handwritten, short answers, not multiple choice. So it takes longer to grade those. So that's the goal tonight, is to get your quizzes graded from last week tonight. And then since this is the last quiz or last lab, exam 3 opens up next week. So I will try to give you all a large window for that. Obviously, when things come down my way, probably this weekend, I will type up my normal study guide, and we will you'll have an idea what's going on with exam 3, and then we're pretty much wrapping up Bio 139 lab, whenever you get done with exam 3. So, like I said, this will be a much longer lab than normal. So let's just go ahead and get to it. I'm going to, I wish I would have brought my charger, but I think I'm good. All right, so antidiuretic hormone. And if you think you know these answers and you see me struggling, just go ahead and say it. Don't embarrass me. Just sit there and because I may have to blank out, because some of these I haven't seen in a long time. I was more concerned about getting the answers to the case studies in these charts, but I think I have an idea from when I was in your all seats. So antidiuretic hormone, you probably remember this from the diabetes stuff that we've gone over in the past. Antidiuretic hormone is produced in the posterior pituitary gland, okay? The posterior pituitary gland, not anterior, posterior, all right? The target organ is the kidneys, all right? And what it really does is that it will, try to retain water in the collection tubules of the renal tubule. So the function is that it reabsorbs water from the kidneys. Now, disorders, this is where I may struggle. Obviously, you have diabetes insipidus, okay? Diabetes insipidus is where you urinate too much. So my guess is this would be a hyposecretion of antidiuretic hormone. Now, a hypersecretion, I'm not sure if I have an answer. If you all have an answer to that, feel free to fill that gap in, but I cannot think of a hypersecretion disorder of ADH. All right, and I need to pull up the chat so I can see everybody's. People are chatting me. Okay. All right. Oxytocin. Oxytocin is also produced from the posterior pituitary gland. ADH and oxytocin, there's a reason why they're grouped together, because they are the only two hormones that are released from the posterior pituitary gland. All right. Now, oxytocin has various targets. However, the main target for oxytocin is the mammary glands located in the breasts. And the stimulus would be probably a baby. If somebody is nudging, if somebody's holding a baby and it's time for breastfeeding, the baby will kind of, I forget what the term's called. It's kind of called nudging or a suckling feeling on the nipple of the breast. That will stimulate release of oxytocin, which will have a target organ of the mammary glands, which produce milk function, or the function is to produce milk for the infant. Dopamine's also involved there, but we won't go into that. All right. Let me know if I'm going too fast, or please speak up. Growth hormone. Growth hormone is produced from the anterior pituitary gland. All right. So the first two are posterior. The first one is coming from the anterior pituitary gland is growth hormone. All right. It is also stimulated by the hypothalamus. It's something releasing hormone. I cannot think of hypothalamic releasing hormone. You all may be able to correct me on that. I'm not sure if you need to know that, but when the hypothalamus releases a releasing hormone, it's slipping on the tip of my tongue, it will travel down to the pituitary gland and release growth hormone. Now, growth hormone has a bunch of different has many targets. The bone would be a large target. And then it will cause stimulus for release. That's the hypothalamic. You can easily do a Google search and find this out. The hypothalamic releasing hormone for growth hormone. It's something releasing hormone. I don't want to change my screen to look it up, but it comes from the hypothalamus. And the function is it kind of alludes to what it is. A growth hormone will cause you to grow. Actually, more growth hormone. The interesting thing here is that it will spike at night. So when you were sleeping or when you were resting is when growth hormone spikes, and you actually usually grow at night when you were a child. Okay, disorders and hypersecretion. Acromegaly is one of them. And then dwarfism is the other. There's a few other ones out there, but I will allow you all to define those yourselves. Or dwarfism, I think, is pretty it's fairly obvious. Acromegaly is just, or gigantism. Acromegaly and gigantism are the hypersecretions of growth hormone, and one is just seen in the adult version. Like I think gigantism is, and then acromegaly is seen in the more pediatric patient. All right, any questions there? Growth hormone does a lot of different things too. It will also control your blood sugar in your, it controls your blood sugar. Also, it does a lot of different things. It actually has a role with estrogen too, because estrogen will target the growth plates, and the more estrogen you have, the likelihood of you becoming more taller as you become older. So you don't have to know that, but I'm just trying to put some context in, is that growth hormone will propagate estrogen, and estrogen will target the growth plates in your legs, in your arms, and then that's kind of how, like, basketball players will have a lot of estrogen because they have more growth hormone, and more estrogen means more growth plate expansion. All right, enough of me rattling on about growth hormone. TSH, thyroid stimulating hormone. Now this one I do remember. This one is also from the anterior pituitary gland, and it will, let's see if I can stick with the TSH will target the thyroid gland. Okay, it also does a lot of different targets. It'll target the parathyroid, but more it will target the thyroid. And the stimulus is thyroid releasing hormone. All right. When you see the stimulus for release, that means they're likely coming from the hypothalamus. And anything that comes from the hypothalamus, it's like blank releasing hormone. Okay. All right. It's something blank releasing hormone. That's when that releasing hormone tells you that it's coming from the hypothalamus. Now, the first column we have, which says gland produced, chances are it's blank stimulating hormone. All right. Kind of helps you keep things in track. So thyroid stimulating hormone will be released from the anterior pituitary gland. It targets the thyroid. The release of the stimulus for release is the hypothalamus. And then the function is all kinds: body temperature, metabolism, hair, skin, and nail maintenance. I think that's all I'm going to put down for that. Oh, and look, you all got lucky. You don't have to do disorders of hypo and hypersecretion of that. All right. Okay. ACTH, adrenal corticotropin hormone. Yeah. That comes from, ACTH will come from the pituitary gland, anterior pituitary gland. All right. The target organ is the adrenal glands. The adrenal glands sit right on top of the kidneys. Stimulus for release is, I think what I just mentioned is that it comes from, no, I didn't. It is the corticotropin releasing hormone. All right. So the hypothalamus will release corticotropin releasing hormone. That releasing hormone travels down to the anterior pituitary gland to release adrenal corticotropin hormone, which will then disseminate out into the body and make its way down to the adrenal glands on top of the kidneys to release cortisol. This is how we deal with stress. So if your instructor got up at 6 o'clock today and realized he had to leave the house at 6:15, he's very stressed out because he overslept his alarm because he didn't get any sleep this weekend. And then he had to have a conversation in the hallway, damn near half asleep with one of his students. And this will cause stress. That's kind of how, stress is. Cortisol levels are likely higher when you first wake up, I guess is the point I'm trying to make. And then as you wake up and you kind of get your act together, stress will kind of lower and become more of a basal level. Yeah, Raymond, did you sense my frustration there? It's just getting late in the semester and I have all these sticks in the fire and I didn't get any sleep this weekend. It's starting to catch up with me. It's just third shift life. It's all it is. It's fun until life gets in the way and then you have to be somewhere at 1 o'clock in the afternoon. That's like you're in the middle of your sleep pattern. All right, luteinizing hormone. All right, guys, now we're going to get into the reproductive side of it. So luteinizing hormone is something that I know, I guess the crazy thing is that I know more about this in the female cycle than I do more the male. I always get it mixed up in the male versus the follicle stimulating hormone. But it's produced by the genitals. Let's do that. It's produced. Actually, no. I think it's produced by the. Excuse me. It's produced by the pituitary gland, anterior pituitary gland, LH and FSH. We may just do these together. LH and FSH. They both are produced by the anterior pituitary gland. All right. The target organs are the genitals. Sorry, because then they're the ones that make testosterone and make estrogen. Stimulus for release. This is the gonad. So gonadotropin releasing hormone. All right. You know, we also said corticotropin. Well, this is gonadotropin. Gonad always means reproductive. So when you hear gonads, I'm sure you've heard that saying, you know, nads, or who's got the nads, or got the gonads to do something. That means they're talking about the reproductive organs. Stimulus for release is the gonadotropin releasing hormone. Function, I might have alluded to it. It's testosterone and estrogen, depending on what gender you are. All right. Any questions? That's the first page. The only thing that I think I didn't really hit too hard on is maybe, no, never mind. I guess I did find the growth hormones. Okay. I couldn't think of the releasing hormone for growth hormones. So look that one up. It's easy. It's just something releasing hormone. It's probably going to come to you at the end of this lab. All right. No questions.
Yeah, it's a growth hormone releasing hormone.
Oh, okay. So it's
GHR.
Okay. Okay. Thank you. Thank you. Yeah. All right. Maybe I was overthinking that. Growth hormone releasing hormone, guys. Let's go back up to oxytocin real quick. All right. And the function of oxytocin, I think I got it mixed up with prolactin because I just saw prolactin. Well, when I told you that it's mammary glands and all that, yes, it plays a role in mammary glands, but there's a bigger function for oxytocin. And I'm sorry, I should have known this. Oxytocin is what, if somebody is in labor and they need assistance with the contractions, they will administer oxytocin in the labor room, and this oxytocin will cause contractions of the uterus to help move the fetus at this point along the vaginal canal. Okay, so the big thing with oxytocin is that it will cause uterine contractions or uterine contractions during labor. Sorry, that one slipped my my brain there. Oxytocin, prolactin, when I was in your all shoes, I'd always get mixed up. Now, prolactin, hence lactin, is the main hormone that produces the milk in the mammary glands. Okay, so prolactin is produced by the anterior pituitary gland. It targets the mammary glands. The stimulus is dopamine. All right. And the function is for milk secretion. All right.
So the function for the target organ for oxytocin.
Uterine lining.
Okay, thank you.
No problem. That was my mistake. As I dust off the cobwebs here. Disorders, hypo and hypersecretion. All right, guys. Put a big circle there for that. Obviously, it's going to be some kind of milk production. Did somebody know it? I don't know this one. If you've seen this in lecture, I cannot think of anything that's in.
I have for hyper. I have abnormal milk.
Abnormal? Is it milk? You said abnormal milk.
Yeah, and for hypo, I have an ability to produce milk.
Okay, so it's easy. All right, so. Hyper sounds like you have more milk, and then hypo means you have less milk. All right. That might have been overthinking that one. Okay.
What did you say the gland produced was for prolactin?
Anterior pituitary gland.
Thank you.
No problem. All right. Thyroid hormone. Now we're kind of getting into the disorders, because now we're getting into what happens when things get released from the thyroid. And that's usually where the problems arise. Thyroid hormone is T3 and T4. Now, I think T3 is much more active than T4. I'm sure you'll learn that in lecture. So this gland, thyroid hormone, T3 and T4, are released from the thyroid gland, right? We have thyroid releasing hormone that comes from the hypothalamus that travels down to the anterior hormone or anterior pituitary gland, excuse me. And then that will release thyroid stimulating hormone. And then thyroid stimulating hormone will leave anterior pituitary gland, travel to the thyroid, which is right around here. And it will release T3 and T4. And that's what really does the main functions. So I guess when I say you can keep thyroid stimulating hormone, you can ask like what the function is. Well, the function is that it goes to the thyroid and releases T3 and T4. T3 and T4 are the ones that really carry out the metabolism issues, the issues, and hair, skin, and nail development. And I just saw that my speaker cut out. Are we okay? Did you guys hear that? Because now we're kind of getting into the target organ, target endocrine organs. So gland produced, T3 and T4 are the anterior pituitary gland. Target organs could be everywhere. Target hormones could be areas in the brain. It could be a lot of different places. I'm going to leave that one. I'm going to leave a big circle on that one because I'm not sure where else. I mean, they go. I can't think of any predominantly area that T3 and T4 go to. Okay. So let's put a big circle on target organs, and maybe I can circle back and remember where these organs go to. I mean, they have T3 and T4 play a huge role in all kinds of different functions in your body. All right, stimulus for release. The thyroid stimulating hormone. And then, as I said earlier, the function would be metabolism, body temperature, hair, skin, and nail development. All right, hypo and hyper secretion. It's not Addison's because that is cortisol. Does anybody know? What is it? It's
Cushing's and Graves.
Yeah, that's what it is. Yeah, I was going to say Medixia or something like that. Graves' disease, yes. Graves' disease, and then what's the other one? It's like you could do like Hashimoto's. I'm sorry. I'm going to turn you up. Does anybody know? Hashimoto's is one. Graves' disease is one. Medixia, or I think is how you pronounce it. Those are the disorders.
Cushing's?
Yes, Cushing's. Thank you. Cushing's. Now, I'm not going to dive into details because I can't not remember which one is which. Yeah. Okay. There's Addison's and, okay, maybe Cushing's is thyroid. One's cortisol, but we'll go into that. All right, so let's make sure we beef up the hypo and hypersecretion disorders. If I come up with anything, I may type some email out to everybody just to get some things straightened up. But this is where my memory is lapsing. Okay, calcitonin. Calcitonin is released from the thyroid, I think, the thyroid gland. The target organ is bone. It is the cause of release is it may be thyroid stimulating hormone. We got to put a big question mark here because I'm blanking on calcitonin's some of the facts of that. The function is for bone. Calcitonin deals with bone. There's parathyroid hormone that will increase or decrease bone. I think calcitonin will increase bone depository. I think. What I mean is that it's calcium. It deals with calcium, so it will deposit calcium to the bones, which I think builds the bones up. All right, so it will lower blood calcium levels. And then I think parathyroid hormone does the opposite. All right. So parathyroid hormone will, just to play off what it does here and to help my memory is that parathyroid hormone will take the calcium from the bone and raise blood calcium levels to become higher. The hypo and hypersecretion of this, if you have hypersecreted parathyroid hormone, I believe that is what happens, or partly what happens with osteoporosis. Because as you remember, in women who are postmenopausal, where the estrogen becomes lower, parathyroid hormone will come a lot higher, and it will rob calcium molecules from the bone to raise the calcium levels to a much higher serum level. And that's why it's important for women who are postmenopausal to take calcium supplements to make sure PTH remain lower and we don't get an onset of osteoporosis. That now hypersecretion, that is hypersecretion. Hypo would probably just be a lower amount of calcium in the serum. If anybody can think of another hypo secreted disorder of PTH, feel free to speak up. So the glands produce is that it will, parathyroid hormone comes from the parathyroid. So we have the thyroid, which is kind of like on each side, and then right on top of it, well, the thyroid is more vertical, and then right on top of it is kind of like where the parathyroid is, right next to it. And that releases parathyroid hormone. And then target organs, I would say bone at this point. There may be more. And then the stimulus for release is the it's not I guess it's parathyroid hormone. No. Let's put a big question mark there for stimulus of release on PTH. It's probably going to be calcium levels. I would say potentially calcium levels for parathyroid hormone. It's not going to be a hormone. It's going to be like a molecule that it controls. That is talking about homeostasis. So things feed back. There's negative and positive feedback. And then when things feed back onto the target from the stimulating organ, and that's how it controls homeostasis. The function is calcium levels for both calcitonin and PTH. I think calcitonin will lower calcium levels in the serum, in the blood, and then PTH, parathyroid hormone, will raise calcium levels. So I know that one was a little messy, calcitonin and PTH. I was a little bit everywhere. Did we miss any gaps that I'm not aware of? Okay. All right. Sounds like we're good then. All right. Epinephrine. Epinephrine, looks like we got what? Oh, we still got a third page. Epinephrine is from the epinephrine and norepinephrine. I'll probably group these together. Epinephrine is from, what is this? The gland produced? The adrenal glands, all right? And more predominantly the adrenal medulla, all right? Medulla, whenever you hear about medulla, that's like the core of the organ, or the inside or the center, right? You've also probably heard of cortex, the adrenal cortex. That cortex means on the outer areas. But when we're talking about a medulla, we're really talking about, in the center of that organ. So epinephrine and norepinephrine will be made from the adrenal medulla. Target organs could be everywhere. The one thing I will probably make an example of would be the heart. Epinephrine and norepinephrine controls the sympathetic nervous system, which will elevate your heart rate and contractility of your heart. Stimulus, I'm going to put stimulus, for stimulus, I'm going to probably put like fight or flight, like sympathetic nervous system. I'm going to stick with that. If you all have a better one, there are many different areas of epinephrine release, but it could be from like fight or flight. If you see a threatening stimulus that obviously you find threatening, you can either run from it or fight it, and epinephrine will be released from the adrenal medullary gland. You can also put acetylcholine. That is another way that will fire epinephrine is the neurotransmitter acetylcholine. And what happens is that epinephrine does all kinds of different functions. I guess I'll just answer functions next. That it will elevate your blood glucose. So your muscles have glucose on the ready in case your muscles need to carry out some kind of function, or whether it be you're fighting this stimulus or you're running from it. It'll also dilate your bronchioles, so you have more air in your lungs, because if your muscles are going to be doing some strenuous activity, then obviously we need to have oxygen supply to the muscles to avoid any lactic acid buildup or fatigue. All right. Now, hypo and hyposecretions on epinephrine. I will refer to any of you guys on this. They are probably, I could guess them. I could pick them out on a multiple choice, but pulling them out of my brain, I'm going to flub up. There's pleochromasia, or that is when you have too much. It's like when you're drinking too much caffeine or something like that, or you produce too much. Circle that one, hypo and hypersecretion of epinephrine, if you do not know which ones those are. It'll be a simple Google search, but I don't want to confuse people if I'm not confident on my answers. All right. Cortisol. Cortisol comes from the adrenal cortex. Yeah, Derek, I'm gonna this is in record. Cortisol is from the adrenal cortex. Cortex means cortisol. That's how I've always remembered it. So the adrenal cortex will release cortisol. Target organs would be the liver. The liver can elevate blood glucose levels, because cortisol, when you're stressed, this is how you kind of develop diabetes over time through stress, is that cortisol will elevate your blood glucose levels, and you will that's if it's a chronic period where you have chronic cortisol levels that are released, then the glucose will remain kind of more elevated than what it should be in the circulation, and that's kind of will cause damage over time. So that's how you develop pre-diabetic onset, I guess is what they call it. It's good to keep a low stress level, I guess is my take-home point. Okay, cortisol levels we've talked about. The liver, I think, is a good target organ. The brain, it does a lot of different things. Stimulus for release. This is the stress will cause the release of this, and it'll also be the adrenal corticotropin hormone from the hypothalamus. We saw that earlier in this graph. Function is to combat stress and elevate blood glucose levels. All right. So hypo and hypersecretion. I always thought Cushing's was more cortisol, but check on that. Maybe it's thyroid. Maybe it's the T3 and T4 hypo and hypersecretion. I always thought
It
it was
might be cortisol because actually my dog had it,
okay.
and so I just remember him having it.
It's high. Yeah, Cushing's is high cortisol. And then Addison's is low cortisol, I think. It also has a role with sodium. So put Cushing's C Cushing's is for C cortisol. All right, I think that's how I remembered it. And it's high. Cushing's is high cortisol, and it can cause a buffalo hump in your back. It can cause retention of sodium. It can cause heart issues. You can just do a simple Google search on Cushing's, and it'll explain everything to you. There's also, in the role with cortisol, is sodium imbalance and we'll talk about that next with aldosterone. Addison's, on the other hand, is hypo secretion. Addison's is where we don't have enough cortisol, and that'll affect, you always have like a low sodium because cortisol. So put Cushing's more towards cortisol. And we will keep Hashimoto's, Medixia, maybe one or two more for T3 and T4. Like goiter, like a goiter would be one for T3 and T4. That's probably the big one I missed up there in the pathophysiology for T3 and T4. Goiter is the big one. Make sure, I forgot to mention that. Put goiter for T3 and T4. Okay. Aldosterone. Aldosterone comes from the adrenal gland. I'm trying to remember which one it comes from, either the cortex or the medulla. I want to say it's the cortex because I think that's why we have cortisol and aldosterone grouped together. But just put adrenal gland. We don't have to get fancy with it. All right. Target organ would be the kidneys. All right. The renal tube, the nephrons or renal tubules of the kidneys. All right. Stimulus for release is sodium balance in the body. And then function, it acts to retain sodium in the renal tubules. All right. So if we are sweating a lot, also we're sweating salt out, right? And we need to have, we're pretty much a bunch of saltwater bags, essentially. So if you're not drinking Gatorade or you're not rehydrating yourself, what your body will do is it'll crank up aldosterone, which will retain sodium in the collection tubules. Well, actually, it's the proximal tubule and distal tubule, but that's here nor there. But it acts to increase your sodium back into your blood, increase your sodium levels back up to 120 millimolar per deciliter or something, millimole per deciliter. So aldosterone, I think, would be coupled with cortisol's hypo and hypersecretion. I think Cushing's and Addison's would be another same answer here for aldosterone pathophysiology. All right. So we're good. All right. Last little bit. Sex hormones from the adrenal cortex. T and E, what they mean by that is testosterone and estrogen. So I'm going to put that testosterone and estrogen are produced by the genitals, male and female genitalia. The target organs would be the genitals, primarily. Testosterone will go and estrogen will go and feed off other sites. This is how we get breast development. This is how we get armpit hair, a lower voice, or a higher pitched voice. Stimulus for release is the gonadotropin releasing hormone from the hypothalamus. So when we get puberty, when puberty starts, it starts from the hypothalamus, given the gonadotropin releasing hormone, which will feed down, make LH and FSH and the anterior pituitary gland. And then when those get ramped up, then all of a sudden we start making T&E, testosterone and estrogen. Function is, primary and secondary sex characteristics. I'm going to leave it at that. And then disorder could be, I can't think of anything off the top of my head. I mean, sterility perhaps is one. There may be some I'm like on that are easy and I'm not thinking of, but I'm gonna leave that to you guys to fill out for hypo and hypersecretion of testosterone and estrogen. I mean, obviously, when you have low testosterone, it's called low T. I don't know the answer to that, but I think they're pretty simple. I think I may be overthinking it. And then sometimes maybe estrogen, too much estrogen can cause different issues in the female developmental tract or reproductive tract. I don't think like cysts or endometriosis is involved in high or low estrogen. I don't think that's it. That's something else. So I can't say endometriosis or anything like that, or polycyst. I think disorders where there's a lot of cysts on the ovaries. I cannot think of what it is.
PCOS.
Yes, whatever that stands for. I'm not sure if that applies here. Yeah. All right, so we'll leave it at that.
Yeah.
Couple gaps there on sex hormones.
Yeah, I guess we have here adrenogenital syndrome,
Okay.
AGS.
Yes. I think
There's
that's,
secretion of adrenal androgens.
yes, androgens. Okay. That is more, so what you just said there is that it basically means that they don't exactly know what they have. They just know they have a hypo or androgen levels. Androgen means low testosterone. Testosterone is an androgen. It's a biochemical term. I think that's the best way to put it. And if I find something in the notes and I want to clear some gaps up, I'll send an email out. But we're going to probably leave it at that. Okay. Insulin, the gland produced is the pancreas. Insulin is produced by the beta cells in the pancreas. Target organs would be, anywhere that has a glucose transporter. I think they're called GLUT2 and GLUT4 glucose transporters that require insulin to allow glucose into the cell. So this could be muscles, this could be tissue, this could be fat, this could be the brain. Basically, wherever you have a glucose transporter. Stimulus for release would be high glucose after you just ate a meal. And function is to lower blood glucose levels. So the big one here for disorders with hypo and hyper secretion of insulin is type 1 diabetes. All right. I think the best example would be, probably be a hypo situation, because type 1 diabetes is where we have to take an insulin shot. So what they think happens is that there potentially is an autoimmune disease that people will catch in their juvenile stages. It's called juvenile type 1 diabetes. And the juvenile part is where people are usually get this in like 18 or 19 or 15 or 16 years of age. Good friend of mine, he got it in college, and what they think what happens is that there's an autoimmune disease that takes out the beta cells in your pancreas. And So you no longer produce insulin. So you have to make your own insulin through through giving insulin yourself through, an insulin pump or a needle. So that is the hyposecretion of insulin. Hypersecretion would probably be more like type 2. That means we have so much blood sugar in our body. We also have insulin, but the problem is that the glucose transporters are becoming immune to, or are becoming insensitive to the glucose. So glucose still hangs out into the, is more elevated in the blood circulation, and subsequently so is insulin secretion. And that's type 2. Type 2 really is just the glucose transporters become insensitive to the sugar. All right. Glucagon is our last one. Glucagon is coming from the alpha cells of the pancreas, I believe. I think alpha cells also are the glucagon producing cells. Target organ is glycogen stores. So basically the purpose of glucagon is that if we are starving, or we are have low glucose for a long period of time and we need glucose, then glucagon will cause the breakdown of glycogen. Glycogen is just pretty much a bunch of stored glucose. And so glucagon will go make more glucose from our glycogen stores. We have about 18 hours of glycogen stored up in our liver and our muscle cells. So anything beyond 18 hours, then we start burning fat, this is what we try to do when we lose weight. We want to get past our glycogen stores so we can start burning fat. So the function is to raise blood glucose levels.
Hey.
I had to make that connection.
Can I share something about that?
Yeah, go ahead.
Recently, my husband and I have been fasting
Uh-huh.
because a lady, one of the nurses at work, she lost a lot of weight. And anyway, so that's so true, because we're not like dieting or anything. We're just doing this like 16-8 fasting thing. So we don't eat anything for 16 hours, and we eat like normal for 8 hours. Not the whole 8 hours, but we just eat normal. And we've been losing weight. So
Mhm.
I didn't know the science behind it. So that is so true. We just said.
Yeah.
Okay.
You're right, Liz. So yes, so when you are eating, whatever you are putting back in your body will likely build up your glycogen stores. Like let's say you go out and you just slam a pizza. All right. So that pizza, all that sugar, glucose will get turned over into glycogen for your stores. And then after that period where you're fast, your body will use that glycogen stores to keep your blood glucose levels, within normal range. Then all of a sudden that goes away. You may feel a lot sleepier or more tired because the calories produced per glycogen store is going to be different from the calories produced per fat. And that ketone diet plays off all this. The ketone diet is huge. As long as you stay hydrated, you might find yourself like going to the bathroom more. And what I mean by that is like urinating, because there's a lot of water in glycogen breakdown. And so you're also releasing a lot of water. The girls at work tried to get me to do some ketone diet. I did it for a little bit. And I just get like crazy ass headaches because when you urinate so much, you're also urinating out electrolytes. And if you're sensitive like me, who just get these frontal headaches from hell, I literally have to go and take these electrolytes and get like a bunch of salt back in me because I was urinating so much just because my glycogen stores were becoming depleted. So, all right. It is interesting. No, it is very, when you get into the biochemistry of it, it can get really cool and explains how things, why things occur. All right. So we wouldn't have a lab without any kind of histology here. Okay. And This is nothing I care to add, but it always likes to show up on exams. Okay, luckily it's the pictures from the actual lab itself. So we have the adenohypophysis and the neurohypophysis. These are the different lobes of the pituitary gland. Number 2 over here is the posterior pituitary gland. It's actually the way oxytocin and ADH are released from the posterior pituitary gland is actually from action potentials. That's the only huge difference. You can kind of see the tissue difference. Number 1 is the anterior portion, and it's much more vascular. Okay, there's a lot more blood vessels going into the anterior pituitary gland, versus the posterior pituitary gland is mostly governed by action potentials. So neurons basically sending electrical conductions, and then those electrical conductions will fire, will fire, and then they will end up on vesicles holding oxytocin and ADH, and that's how they become released. So 2 different mechanisms there, and it's kind of cool. All right, so what is this? Thyroid? Yeah, thyroid gland. There's nothing for me to add. I can't. This is probably beyond my memory here. You have parafollicular cells, which may be part of the parathyroid hormone. And then you have thyroid follicles. It's just best to identify these guys if you have to. All right, pancreas and adrenal gland. The adrenal gland is probably something I want to touch on real quick, because this is kind of where you get into the medulla, which is down here, versus the cortex over here. So adrenal cortex means cortisol, and I think subsequently aldosterone too. Each one of these layers produce a different hormone. Okay, I don't remember which ones they are. 5 and 7, this is the cortex here. So cortisol will be released somewhere in here. The adrenal medulla, this is where you get your epinephrine and norepinephrine. Okay. To the left, I skipped, sorry, pancreas. So you have your insulin of Langerhans, number 1, right here and right here. Those may be where your beta cells are located. Don't quote me on that. And you have your anansi cells, and then you have your pancreatic duct. Nothing further from me to add there. Okay, looks like we have a model key here. We need to get to the case studies. Know what disorders are associated with which hypo and hypo for each. Okay, that may take some time. I'm not sure. So they want you to identify hyper or hyposecretion from each of the disorders. You're probably not going to be able to find all those. I would not spend too much time on page 106. I mean, I would do the best you can, but if you can't find the big ones, like this would be diabetes here probably. Adrenal medulla we talked about with epinephrine, norepinephrine. Adrenal cortex would be cortisol, which would be Addison's and Cushing's. Adrenal capsule, well, there's no disorder there. This is too vague. Parathyroid hormone would be your calcium levels. Okay, so osteoporosis would be one, I think, and then also like low calcium levels. Do your best here. That's what I'm trying to say. Do not go overboard and just beat your head up against the wall with this. All right, so I want to see. Let's see. I know you guys. See if we have answers here. Okay, you don't have answers. All right, that'll be something I'll have to send out. And then I'll have to send out this too. So I'll take pictures of that. Okay, now I'm going to sit down for these, and then we need to kind of get on this because these will eat up some time. All right, and I'm going to stop sharing this, and I'm going to bring up mine because I had to write all these out the other day. Okay. So let's get going. A 19-year-old BCTC student was admitted to the UK Medical Center because of an extreme fatigue and weight loss. For the previous year, he had tired easily and was no longer able to study anatomy and physiology as he should to get in a decent grade. He had lost 64 pounds in the last 2 years in spite of an increased food intake. His present height is 71 inches and 140 pounds. About 4 years previously, he began to urinate frequently at night, and since then had increasing thirst and high urine output. He came to the hospital because during the last 24 hours, he felt awful, quote unquote, awful, and extremely thirsty and irritable, and drank about 360 mils of glasses of water. He was urinating hourly during the last 24-hour period and seemed unable to get enough to drink. His gums were sore, and he had recent difficulty eating because of his gum tenderness. Gum tenderness, I have to say, that doesn't ring any bells there. We'll see what we're trying to get in here, why that is such something worth noting. All right, so his results on the physical exam, we have 435 milligram per deciliter blood plasma glucose. So in the hospital, anything above 400 is considered a critical value, which means you have to have immediate intervention when those glucoses are that high. So this would be considered a critical result from a lab standpoint, and the physician or nurse would probably want to address this quickly. Okay. Specific gravity in the urine. So this, if you remember, this is the concentration of urine, basically specific gravity, which just seems to be normal. Well, a little bit on the elevated side. So that means that, pardon me, he has a much more concentrated urine, which probably would mean that the body is trying to retain as much water as possible because he may be in a dehydrated state. That's why we care about that. 4+ reaction of glucose. So we have lots of glucose pouring over into the urine. This is kind of much the release valve of the body when we have too much glucose and we can't store it in our cells. And we have a moderate reaction for acetone. Acetone is the byproduct of fat metabolism. All right, so think about it. If we can't get glucose into the cells, then we cannot utilize glucose as our metabolism for energy, to make ATP. So when the body can't do that, we result to fats or ketones, like the ketone diet wants to do this. And that is we get this acetone, which is a byproduct of fat metabolism. And then once we're done with it, we either breathe it off. Acetone is what's called a volatile molecule, or we urinate it out. All right, beta hydroxybutyrate is another one, but we won't touch into that. Plasma, pH 7.25. It's a little bit more on the acidic side, okay? Carbon partial pressure, that's what that P is, the partial pressure of carbon dioxide, 30 mmHg. What is that, millimeters per mercury? So what is that? If you remember, CO2 deals with, that will pretty much tell how much acidity is in your blood, and if we are a little bit low on CO2, that means that we're breathing a lot of CO2 out. We're kind of like hyperventilating, okay? And that means that is more basic. So he is compensating for the pH being low by breathing off more CO2, which means he's breathing off more acidity molecules to help get his pH back up. That's why his CO2 is low. Do we follow that? Are we getting that? That's a big deal. Okay. I guess we are. Bicarb, HCO3, that's bicarb. So we're low on bicarb. Bicarb is pretty much a basicity molecule. So the more bicarb we have, if your stomach is upset because if you have what is it? Acid reflux. That's what I'm talking about. Acid reflux after you just had pizza, or you're stressed out, or you haven't sleep, I had this over the weekend, you take bicarb pills, you take antacids. Antacids are bicarbonate. That's all they are. And so when you chew those antacids, I had to do them this morning because for whatever reason, my stomach was upset, and the bicarb will help combat the acidity in your body. And so in this case, he's low on bicarb. So it would be more acidic. Hematocrit, that is pretty much the blood, the RBCs and plasma in your serum. Plasma would be clotting factors, electrolytes, glucose, everything that's pretty much made up of your circulation. And it's elevated. Okay. And what that means is that when we have a higher concentration of stuff in our circulation, that it just means that we're low on water, because we also have water. So it's either more concentrated or more dilute. So this kind of goes into what we set up here with the specific gravity. So we know specific gravity, that's a little bit more elevated. So we have a high concentration of that. And so we're trying to pull water out of the urine and put it back into our hematocrit because our hematocrit is too high. It's at 55%. It needs to be between 40 and 50. Blood pressure, 105/50, and then lying down, 130/68. I can't think. I mean, obviously 105/50 is low. I don't know any indication of why it would be 130/68 lying down. Probably because our plasma volume is low because we're dehydrated. You can always drink water and get hydrated and kind of help boost your your blood pressure up. All right, standing pulse, 104 per minute. Obviously that's high. All right, our respirations are going to be high, right? Because if you think about it, we set up here and the partial pressure of CO2 were low. All right, that's because we're probably hyperventilating to get this pH back up, hyperventilating to blow off the CO2 to try to get our pH back up. All right, so let me know if I'm going too fast. This is where we pretty much connect all the dots of 139. We're going to be drawing on all these different topics and points when we've learned every week. So I'm going to try to connect all these dots, and really this is how you diagnose people if they were to come to the physician's office or emergency department. Okay. What condition does our DCTC student have? They have it's diabetes mellitus, okay? It's diabetes, and particularly mellitus. Why might he lose weight when his plasma glucose is up? I got to get him a drink of water. Why might he lose weight when his plasma is up? Well, it's because he doesn't have any insulin. Okay? If we have a drop in insulin, that means we have a drop in glucose uptake, and we have further breakdown of fat and protein for energy. All right. Are we following this? Can I get some feedback here?
It makes sense.
Okay. All right. This is kind of a big deal. You could sit here and memorize these and write them down, and you'll get slaughtered on the exam because the exam is going to take all these different points and try to tie them in. And you can always tell the students who memorize what I said because they bomb out on exam 3, and the ones who understood and connected the dots and drew arrows and tied all these concepts together did fairly well in the exam 3. So if you are not following this, please ask questions or drop me an email because this is kind of a crucial time to make sure we know we are understanding, physiology. All right. What is the acid-base disturbance? All right. So it looks like he had ketoacidosis, which means is that when you have ketones on board, more ketones mean that it causes acidity. So that's how you get ketoacidosis. And predominantly it's metabolic acidosis because your bicarb up here is low. All right. 14 milliequivalents per liter, which is low. That's the metabolic acidosis part. All right. Explain his respiratory rate. How does it relate to in question C? Well, the respiratory rate is compensating for the metabolic acidosis. All right. So we have a decrease in pH, which will cause an increase in respiratory rate. And the increase in respiratory rate helps blow off more CO2 from our body. So we decrease our partial pressure of CO2, and that subsequently will increase our pH back to normal. Explain what causes his high urine output. So the answer here is osmotic diuresis. Basically what that means is that there's so much glucose pouring out into the urine and moving its way through the nephron is that the glucose will draw in more water into the urine through osmosis. Water goes from low concentration to high solute concentration. So the solute in this case is the glucose because there's so much of it. Will draw water into the kidneys, well, into the collecting tubule, which will dump out into the bladder. Okay. Explain his hematocrit. Well, it's just dehydration. Okay. The one thing is like your hematocrit's made up of, X amount of RBCs, white blood cells, plasma, clotting factors, electrolytes, hormones, and then the rest of it is essentially water. All right. So when we're low for dehydrated, you're going to have a much lower blood pressure. And then you're also going to have a higher hematocrit. So what you do to lower that, you just give them some saline, a couple bags of saline. Old people are always dehydrated. They always have to come in and they need like two big old bags of saline because they're like dried out. They're bone dry, is what they say. Explain why his pulse rate is high upon standing. Yeah, this is a tough one. This is the arterial barrel reflex. Okay. Now, I want you all to expand on that. I want you to go back in your notes and expand on the arterial barrel reflex. We've gone over it earlier this year. It's basically where we have barrel receptors in our carotid and barrel receptors on top of our aorta, and that will modulate our heart rate and blood pressure. So I gave you the concept. I want you to expand on that. Discuss his ADH levels. Explain why they are high or low. All right, well, it's going to be high, okay? His ADH levels are going to be high because we want to try to retain as much water as possible to combat the osmotic diuresis going on. So high ADH means high plasma osmolality, and that's what we're trying to get back to. It will also, when we increase, if we're trying to bring in more water back into the circulation, this will also help our blood pressure and blood volume. So an increase in ADH will also combat the high plasma osmolality, and it will combat the low blood volume and low blood pressure. Okay. What would be possible treatment for his condition? Give him insulin and everything works out. It's amazing. One simple thing with insulin could solve all this. And when we let me this is important because this has gone up in the past too, and this is something important. I want you guys to listen. When you are reading these questions, you have to read them carefully, because it will ask you what is causing this, and then it'll ask you what the body's response to this will be. All right. Like there's homeostasis, right? Where the body is going to try to correct it by moving something else to cause something else to move, right? Back to homeostasis. If the question asks you, what is the body's response to this abnormality? That's when you answer, okay, the body's going to raise the respiratory rate to blow off the carbon dioxide to correct the acidity. If the question asks you what is causing this, then you have to identify what the problem is, not the solution. You have to identify the problem. All right. You'll see these on the quiz and on the mainly on the exam, because there'll be multiple choice questions that will ask you what the problem is, and it'll give you all the solutions, and then students get suckered in to answering for the solution when the question asks you for the problem. So it's very important that we slow down and we really ask ourselves, what is this question asking? I mean, it'll cost you a letter grade. I've seen it in the past. This is kind of where you start getting into the elevated physiology, that you're going to probably use in your careers. All right, so a 45-year-old male from the Midwest presented with the following symptoms during February: weakness, fatigue, orthostatic hypotension, weight loss, dehydration, decrease in cold tolerance. This is his clinical chemistry results. All right, so sodium is low, 128 milliequivalents per liter. Potassium is high. That's actually considered critical. Too much potassium will stop your heart. And then fasting blood glucose is far low. It's 65 milligrams per deciliter. All right, hematocrit is 50% hematocrit, which is high. Leukocytes, that's your white blood cells, that's normal. All right, so we also noticed increased pigmentation, tanning, on both exposed and non-exposed portions of his body and back. The plasma cortisol determination indicated low cortisol level. Following administration of adrenocorticotropin hormone, plasma cortisol did not rise significantly after 60 or 90 minutes. Endogenous circulating levels of adrenocorticotropin hormone were later determined to be significantly elevated. All right, so we got a lot going on here. What endocrine organ is the site of this malfunction? All right, well, this is referring back to feedback loops, negative and positive feedback loops. We really didn't go over much of this in lab. I think it's more of a lecture term. So you may have to draw on your lecture knowledge to answer some of these. But this is a negative feedback loop that the answer is adrenal cortex, right? Because cortisol is not feeding back to the pituitary gland, and that's why we're getting significantly high adrenocorticotropin levels. So it's an issue at the adrenal cortex. All right. Now, it asks you, is this a primary or secondary disturbance? Well, it's a primary. Okay. And then how do you know? Well, we know it's because increased adrenocorticotropin hormone did not raise the cortisol. All right. Now, what is the name of this disorder? It's called Addison's. This is Addison's disease. Addison's disease is low cortisol. The opposite, high cortisol, is called Cushing's. In this case, it's Addison's, so it's low cortisol. And this is kind of where we're going to get into the electrolyte imbalance with Addison's that I was kind of alluding to earlier. All right, so discuss the electrolyte disturbance resulting from this disorder. All right, whether it's normal or diseased. I'm going to say pathology, pathophysiology is obviously diseased versus normal. So when we have, well, I should say that Addison's also involves low aldosterone. Let's take it from that perspective. When we have low aldosterone, because that is part of the Addison's manifestation, clinical manifestation, it causes a decrease in sodium, right? Now, I told you up here in the very top, we had a 128 milliequivalent per liter, all right? So that's low sodium. Now, we also have a very high potassium, and this is indicative of aldosterone. We have potassium is high at 6.3, and that's correct. All right, now I want to stop here and I want to give you the definition of what aldosterone does. You probably didn't remember this in lecture, but you're going to hear it from me. Aldosterone works to retain sodium in the renal tubules. So, and what it also does when it tries to retain sodium, it kicks out potassium. All right, it's like it swaps out. So when we are low on aldosterone, subsequently we would have low sodium and a high potassium. And that's exactly what this guy has in his clinical chemistries. Hope I didn't find that confusing there. I wanted to try to, if you understand the definition of aldosterone, then you will answer part D very easily. Because aldosterone, if we have aldosterone that's working normally, that will retain sodium and kick out potassium. When we have a drop in aldosterone because of Addison's, we do not retain sodium as well, and we retain way too much potassium. Too much potassium will stop your heart because it hyperpolarizes the action potentials. And if you remember action potentials, potassium will hyperpolarize the action potentials. And if you do not reach the threshold for an action potential in the SA node, you are no longer beating your heart. If you go to the, what is it, the gas chamber, or what's it called, the death chamber, when they sentence somebody to death, you know what they give them? They give them a huge ass dose of potassium. And what that does is that it will, like I said, it doesn't allow the action potentials to reach threshold. And really it's in the heart, it's in the SA node. And so if you don't reach threshold in the SA node, then you've pretty much eventually decreased your heart rate so much to where you'll lose consciousness and you'll die. That's how they, I guess, humanely in their eyes, give somebody the death penalty. Okay. Discuss the glucose disturbances resulting from this disorder. Well, it's going to be a decrease in glucose because if you might have recalled, cortisol also will raise your glucose. So in Addison's disease, we have low cortisol. So if we have low cortisol, we will subsequently have low glucose, which is not necessarily a bad thing. But that's why you have a low glucose here. Okay. Now, what is causing the tanning? All right, this is getting into the high weeds for me, from what I'm trying to remember. So when you have low cortisol, that's where the issue is. That will cause an increase in adrenocorticotropin hormone, ACTH. All right. High levels of ACTH will cause melanocytes in your skin to increase. All right. It will stimulate them. It'll stimulate melanocyte production. If you have more melanocytes or more melanin, melanocytes make melanin. If you have more melanin in your skin, you tend to have darker skin. So this will increase your tanning. All right. Melanocytes make melanin. Melanin is responsible for your tanning of your skin. All right. G, what type of replacement therapy would be required for this individual? Well, you give them exogenous corticosteroids. All right. They would take a shot of steroids, basically. Exogenous means outside the body. G, describe the feedback loop for this endocrine disorder. What is the loop? Where is the loop broken? Well, it's broken at the cortex, okay? So let's just start from the top. You have the hypothalamus that releases corticotropin releasing hormone. That will travel to the anterior pituitary gland. That anterior pituitary gland will release adrenal corticotropin hormone, which also is an increase in POMC. We didn't go over POMC, but I want you to write it down because it may show up on a lecture exam or something. And POMC is an abbreviation for some long biochemical term that I cannot think of it. I've just learned it as POMC. All right. And then that adrenal corticotropin hormone will travel to the cortex. The adrenal cortex is what we're talking about. And then from the adrenal cortex, we will get an increase in cortisol, aldosterone, as well as, I'm going to bring in some reproductive stuff here, increase in testosterone and estrogen. It's not as much, but it's still there. And so that cortisol, that increase in cortisol, the feedback is that it doesn't go back to the hypothalamus, right? So it's broken at the cortex because cortisol, for whatever reason, is not doing its negative feedback job by going back onto the hypothalamus. All right. Now, number 3, the last 6 or the last 3 or 4 of them are relatively short. So we got about a half hour, so we'll be okay. 38-year-old female visits her doctor complaining of chronic fatigue and weakness, especially in her legs. Upon greeting the patient, the doctor notes that although she is mildly obese, there is an unusually round contour to her face. During questioning, the long contour of their face tells you right there, it's Cushing's. During questioning, he learns that after a recent 20-year high school reunion, nobody recognized her because her face looked so different. Because examination yields an unusual fat distribution, that's the buffalo hump, the fat distribution in the buffalo hump on her upper back. And it's with marked centripetal obesity. So centripetal obesity is otherwise what we call like the inner tube. That, you know, if you carry a lot of weight around your waist, inner tube, kind of like that, tire, I guess, what other people call it, their blood pressure is relatively high. So this is Cushing's. This is an increase in cortisol. This is opposite of Addison's. All right. You get the moon face, which is the round contour. You get the buffalo hump. This is like the easiest one. If they ever give you this on an exam, you know exactly what it is, and it's Cushing's. There's nothing else like it. The buffalo hump is the fat distribution. For some reason, the fat becomes deposited in your upper back, and you get a chronic levels of cortisol will eventually just erode the body. You get a loss of muscle and bone, and you do feel weak because of this, and you also have high blood pressure. All right. So I'm assuming we're caught up here. Number 4, Mr. Jessup, 55-year-old man, is operated for a cerebral tumor. About a month later, he appears in a physician's office complaining of excessive thirst. He claims to have been drinking about 20 liters of water daily for the past week and voiding nearly continuously. A urine sample is collected and specific gravity is 1.001. So our standard for specific gravity, that's like water. Like distilled water is 1.000. All right. So we pretty much refer anything up against that. So basically what he's doing is he's just peeing out water is the take-home point. So it's very dilute. Oh, excuse me, I had to stretch. What is your diagnosis? Well, this is called diabetes insipidus, all right? And the insipidus part on the diabetes side is basically where somebody just urinates water continuously. I mean, they may urinate a gallon of water a day, something like wild. It just goes right through them, as they say. and they drink a lot. So explain both types of diabetes and how they are different. Use your text, both renal and endocrine chapters. All right, well, I might have just answered half of this. Diabetes insipidus is an ADH disorder, okay? Antidiuretic hormone disorder. So we don't have a lot of ADH. So that will decrease our urine specific gravity, which means there's no glucose in the urine. Well, it doesn't mean that. That's part of diabetes insipidus, that there is no glucose in the urine. Diabetes mellitus, that is an insulin disorder. And we have high urine specific gravity. And we have glucose in the urine. So that's, those are like diabetes insipidus versus diabetes mellitus. And if you want to expand on that in your renal and endocrine trappers, I certainly encourage you to. All right. So explain both types of diabetes insipidus, right? So we have neurogenic and then we have nephrogenic. So neurogenic is dealing with the brain, the nervous system, right? And the problem is that we either have an issue with the hypothalamus or the posterior pituitary gland, right? And that is like usually a decrease in ADH. And then nephrogenic, when you see nephrology or nephro, you're really dealing with the kidney. And subsequently, you're dealing with the nephron. Or in this case, we're dealing with the collection tubules or collecting duct. And we have a high ADH, and then we have an issue with it's like a genetic issue when we're getting the ADH, getting the aquaporins into the collecting tubule. Aquaporins is the water channel that reabsorbs water from the collection tubule. And they think this is more of a genetic issue. Something's occurring that is not allowing the aquaporins to insert into the collecting tubule to retain water back into the body, despite having high ADH. So if we can't retain it, then we're just urinating it all out. All right, number 5. Sharon went to her doctor with the following symptoms: dual facial expressions, droopy eyelids, puffiness in the face, sparse, dry hair, scaly skin, evidence of an intellectual impairment, lethargy, a change in personality, bradycardia, blood pressure, she's anemic, she's constipated, and she's hypothermic. All right, this is the thyroid, because the thyroid does so much. That's the problem. When you have issues with the thyroid and you don't compensate with them with, exogenous or some pharmaceutical agent, it can throw you out of whack almost in every facet of the body. Plasma concentrations of T3 and T4 were low. All right, well, right there, that tells you T3 and T4 are low. It's hypothyroidism. All right, this will probably help fill in that little gap that we missed, that I blanked on up there in the chart. So hypo and hypothyroidism right in front of my face. It's not very hard. I said Hashimoto's and I said Medixia, and those are answers too, but the most probably important ones are hypo and hyperthyroidism. TSH levels were elevated, okay? Following administration of exogenous TSH, plasma T3 and T4 did not rise after 2 hours. What is the disorder? It's hypothyroidism, okay? Because we still have low T3 and T4. And this is a primary disorder. All right. Would you expect to find a palpable goiter? Yeah, you bet. Okay, because we have decrease in T3 and T4 levels, and that will stimulate TSH. And if you remember where TSH comes from the anterior pituitary gland, which will stimulate the follicle cells in the thyroid gland. The follicle cells are the cells that create the goiter in the thyroid. Describe the feedback loop involved. Where is the loop broken? It's broken at the thyroid. All right. So let's see if we can take us, see if I can try to take you through this. So let's start at the hypothalamus. The hypothalamus will release thyroid stimulating hormone, okay? That will act upon the anterior pituitary gland, which will increase thyroid stimulating hormone, TSH. TSH will travel to the thyroid, and then the thyroid will increase T3 and T4, right? And then it'll also go as target cells. But T3 and T4 increase never feeds back onto the hypothalamus, all right? So it's broken at the thyroid. All right, so it describes a suitable treatment for Sharon. Well, she has to get T3 and T4. So I think what I found in past semesters is that it's called Synthyroid, SYN thyroid, and it's a pharmaceutical agent that you can be prescribed. All right. Let me take a breath here and make sure you all are writing this down. Number 6, Mary Frances had a total thyroidectomy following the thyroid hormone replacement therapy. A few days later, she developed laryngeal spasms and mild tetany and cramps in the muscles of her hands and arms. The following tests were performed. Okay. So I'll just tell you what's up and what's down based on, what I do for a living. Besides teaching you guys, urinary calcium is so when we have a lot of calcium like that, that's high. 20 milligrams per deciliter of urinary calcium is high. Plasma calcium is low. That's probably around 10. 10's normal for plasma calcium, so we're low on that. Urine phosphorus, we usually try to retain as much phosphate as we can. So when we have urine phosphorus, in this case, would be decreased. All right. Well, I guess what I meant to say is that we have a lot of phosphorus in our diet, so we try to retain as much phosphate as we can, and then whatever's left on top of that gets put into the urine. So it is still low. All right, and our plasma phosphorus is 5.0, and that's high. It should be probably around 3.5 or 4. All right. Calcium and vitamin D were given orally each day, and the tetany and laryngeal spasms were alleviated. All right. So when we're talking about calcium and vitamin D, we didn't really talk about vitamin D as much, but calcium really is controlled by the parathyroid hormone or parathyroid organ gland. All right. So what endocrine disorder does Mary Frances have? She has hypoparathyroidism. Okay. Because the plasma glucose is low, and she's urinating out a lot of calcium. So hypoparathyroidism. What caused the tetany and laryngeal spasms? Tetany and laryngeal spasms are caused by a decrease in calcium. The tetany deals with the muscle spasms. We also have to have calcium and other things to allow some muscles to relax. And it's due to a decrease in parathyroid hormone. And then it says, what is the purpose of vitamin D administration with the calcium? Well, vitamin D allows for calcium absorption in the gut. This is something else that's called intrinsic factor. You might have learned it in lecture. Intrinsic factor will act upon gastrointestinal cells to reabsorb calcium in the gut. So when you go out and you get sun from vitamin D, it also plays a role in reabsorbing your calcium in your body. All right, that's it. Any questions? That's a lot of material. So this will take forever to upload on the internet. It's going to be almost 2 hours of content to upload. It'll be done probably sometime tonight. I'm sure some of you guys who maybe want to hear this again, and I will try to get it up sometime overnight, and you'll get the little notification, I guess. But you can find it on YouTube, on my channel, and we will go from there. This will probably be the last time we meet officially. Carla, I think I just did. I think the case studies is the quiz. I think it's pretty much that. Now you want to, it is timed, and there's 20 questions, and you want to make sure you have your answers ready to go. That would probably be in your best benefit there. So this will be the last time we meet officially. As soon as I get the exam, I will send you all out the study guide, and then and check the syllabus. It's going to be over, obviously, endocrine and reproductive, I think, is what that's the only thing we've done. So mostly endocrinology. I stress that you really read the question and answer what it's asking, okay? And then we will go from there. And I need to grade your quizzes tonight too. I need to update your quizzes, and then after that, that's a wrap. So please reach out. I'm going to go home and take a break. I think I put it as Sunday, Carla. And then I will read your email, or if you did email me, I'll check my emails later on tonight. All right. And I think that's all I have for today. It's been a big day. Try to digest some of this material, and then we will kind of go from there. All right, guys. Good luck on the exam, and reach out if you got any questions.